So here we are going to start the dissection of the anterior abdominal wall. The anterior abdominal wall has different layers. The outermost layer is the skin. Beneath that we'll find the superficial fascia. Now the superficial fascia, it is having two layers. One layer, it is the superficial layer which is fatty and known as the campus fascia. And beneath that we have the membranous layer of the scarpus fascia. So when we remove those two layers, we can see the muscles. So here you can see the membranous scarpus layer. Now looking at the direction of these muscles, you can see they are moving downwards and medially. Hence these are the muscles, these are the fibers of the external oblique muscle. Giving a some important surface landmark, in the midline we have the linea alba. This is the umbilicus, which is a scar in the anterior abdominal wall. This is the site through which the placenta was connected to the fetus. Now, on both sides, we have the linea semilunaris. An incision given along the linea semilunaris, and we have reflected the first layer muscle, that is the external oblique. Beneath this, we can see the fibers of the next layer of the muscle, that is the internal oblique. Pause. Looking at the direction of the fibers moving downwards and medially, that is in the hands in the pocket direction, these are the fibers of external oblique. Now we can see as these fibers they approach the linea semilunaris, they are becoming membranous or aponeurotic. So giving an incision and reflecting this muscle, we can see the fibers of the next layer of muscles, that is the internal oblique. Here we can see these fibers, they are directed upwards and medially like hands towards the heart direction. So this is the internal oblique. External oblique, as we reflect it, we can see the fibers of internal oblique. The direction of the fibers shows that. And when we lift this, we can see the third layer of muscle having the direction in the same way as the internal oblique, that is the transversus abdominis. Now as we reflect it, we can find the fascia transversalis. So we identify this muscle as the external oblique. As it approaches the linea semilunaris, it becomes aponeurotic. Also, here we can see beneath it is becoming aponeurotic. Now, as it approaches the inguinal region, this external oblique aponeurosis, it folds upon itself. It folds upon itself to form the inguinal ligament. So we can find a thick band from the ASIS or the anterior superior iliac spine to the pubic tubercle. This thick band is the inguinal ligament. This is nothing but the upturned free margin of the external oblique aponeurosis. Now beneath we can see this muscle which we had identified as the internal oblique. This internal oblique, we can see its fibers, they are arching over this inguinal ligament and moving downwards. Medially, they are fusing with the fibers of the next layer, that is the transversus abdominis. Together, medially, they form the conjoint tendon. Medially and posteriorly, they will form the conjoint tendon. The external oblique aponeurosis, from the ASIS to the pubic tubercle, the free margin is upturned. This upturned free margin is forming this inguinal ligament, which I have cut open. On opening, we can see a thick structure moving inside the medial aspect of the inguinal ligament. Now that medial aspect of the inguinal ligament is the inguinal canal, and this thick cord-like structure is the spermatic cord. So we can see a defect in the innermost layer, that is the fascia transversalis. Through this, the spermatic cord moves out. So this defect in the fascia transversalis from which the spermatic cord is emerging is known as the deep inguinal ring. This spermatic cord then passes through the different layers and finally moves into the scrotum through a defect in this external oblique aponeurosis that is known as the superficial inguinal ring. So this is the site of the superficial inguinal ring. Even in case of a live human being, the spermatic cord can be palpated at this superficial inguinal ring just lateral to the pubic tubercle. The passage of the spermatic cord from the deep inguinal ring to the superficial inguinal ring. Deep inguinal ring, defect present in the fascia transversalis. Superficial inguinal ring, it was a defect in the external oblique. Now, as we trace the spermatic cord, we can see it moves down into the scrotum, and this is the testis, the upper pole of the testis. We have already removed the outer layers of the scrotum, that is the skin, superficial fascia containing the dartos. We removed the external spermatic fascia, and here we can see the cremasteric and internal spermatic fascia lining the outside of the testis. On the under surface, we can see a thick fibrous band attaching the testis to the scrotal sac. So this attachment of the base of the scrotal sac to the lower pole of the testis is the gubernaculum. So now we have completely resected the spermatic cord and we can trace it up to the scrotum. This is the upper pole of the scrotum. Here we can see it is all covered by the internal spermatic fascia. If we remove this, we will reach the next layer, that is the tunica vaginalis. So the tunica vaginalis is nothing but a serous membrane, which is an extension of the peritoneum which descended along with the testis during the fetal growth. The descent of testis is completed by the time of birth, and in case the descent is not complete, then it is a condition which is known as cryptorchidism. So here I am removing the other layers of the testis.